Good afternoon. One of the enormous privileges of being the dean of an institution of this caliber is to be able to open conferences of this quality and stature. Co-sponsored by the Cleveland Clinic Center for Ethics, Humanities, and Spiritual Care and the Center for Genetic Research, Ethics, and Law, this conference, sponsored by our Law and Medicine Center, is really of an enormous caliber that characterizes everything that we do. Our Law and Medicine Center was the first in the country, founded in 1953 by Oliver Schroeder. It has since then been at the forefront of the intersection of law and medicine, and has worked to help educate future lawyers as to how they can help improve the quality of our nation's healthcare system. I'm pleased to say that even now that Law and Medicine Center is beginning to branch out around the world with an initiative in China that we're in the process of developing. Notwithstanding the competition, I would like to recognize my four colleagues who together run the Law and Medicine Center. Max Melman and Sharona Hoffman, who co-direct, and Jessica Berg and Rukiya Yerby, who are the associate co-directors. Part of the reason that we can host such spectacular programs is the collective and individual remarkable talent of these four people and of all of my other colleagues associated with this center. So, you have much more interesting things to do today than listen to me. Without more than, I'd like to introduce Jessica Berg, who I gather has got some housekeeping remarks. Enjoy the conference. I look forward to stopping in from time to time.
Thank you and welcome. I'm sorry we got a slightly later start. We are getting ourselves together here. A couple things that just to reiterate, if you haven't already gotten your lunches, you can get them back in A66. They'll be out there for a little bit longer. If there are any questions that you have, please feel free to contact me throughout the day and any of our staff that we have here. Also, if you're signing up for any of the CLE or CME credits, make sure that you've signed in appropriately on registration sheets and gotten all the materials that you need. Again, questions, please come and see me. So I'm going to introduce to you my co-director for the conference, Dr. Ruth Farrell. This is very much a conference that comes from her initiative and her thoughts about something that would be a very important thing to do. When she came and described the idea in its first iteration before we knew that we actually could sponsor it here, I said it was a phenomenal idea. I wanted to see it moving. We've gotten the great opportunity to actually host it here. We have some really wonderful speakers. Thank you all for coming. I'm looking forward to all of your talks. And actually, my remarks are simply just that, to welcome you and let you have Dr. Farrell.
Thank you so much for the chance to be here. Really, it's a dream come true. I want to thank the law school. I want to thank Alice Simon and Nancy Cantor for the help as well. But particularly, I'd like to thank Jessica Berg for my co-director for helping me with this, for making it happen. And also, when I suddenly became a mother in February and took some time off for that, she took the reins and made this happen. So thank you so much. Where were you in 1991? Do you remember 1991? What you were doing? What was going on? Let me jog your brain with a couple ideas. One of my favorite all-time movies, Thelma and Louise. But this is an important part of popular cinema about two strong women who are breaking the rules about what the standards were, about what women should be doing and what they would be doing. The world was in transition. The Soviet Union had dissolved after the resignation of the leader. And also the Persian Gulf War was going on. This was advances in technology. This was a cell phone. Do you remember having a cell phone like this? 10 numbers in auto dial, that was a big deal. We had other cultural icons who changed the music industry, that changed the way we see the world, the way we see ourselves in the world. And finally, Demi Moore exposed the pregnant body on the public forum like no one had seen it before. So now as you think about 1991, let me tell you about something else very important that happened at that time. Karen Rothenberg and Elizabeth Thompson organized the first conference at NIH to talk about women and prenatal genetic testing. It was a landmark conference. No one had talked about this before. They asked some of the most foundational questions about technologies. How do the ethical, social, and legal implications of new genetic technologies affect the health and the well-being of women? They were guided by other very important questions as well, and I'll just summarize them. But these are the publications that came from that conference, and I highly recommend that you read them. How can we ensure that prenatal genetic technologies are aimed at increasing individuals' control over their own reproductive lives, that they're voluntary, that they're value sensitive? What are the ethical, social, legal, and economic constraints on prenatal genetic technologies and reproductive medicine, and how can we either remove them or prevent them from ever developing? And how do these advances change notions of health, illness, and disability for both individuals and society as a whole? So much has changed since then. We've gone from chromosomes to genes to genomes. We've gone to whole genome sequencing. We've gone to microarray multiplex testing. So much has changed in the landscape of genetic testing, and these are now coming down to the area of prenatal care and obstetrics. But it's not just about the genetic technologies, it's also about the field of OBGYN, how that is changing. We came from using ultrasound, chorionic villus sampling, or CVS, and amniocentesis as the main ways to image the fetus, with now new ways of screening, new ways of seeing the fetus in utero and performing in utero diagnosis, and now, though still experimental, the idea of maternal fetal surgery to correct some issues identified in utero. So the world has changed. And new challenges have arisen with it, and I hope that we're going to be here to talk about that today. But the interesting thing is that many of the questions are the same. They haven't changed. They're still unanswered, and we still need to answer them, even though the technology has moved forward and we're on the horizon of it really accelerating even faster. So to reflect back on those questions, the questions asked in 1991, the questions that drove that conference, the questions that would like to drive this meeting here today, are the same, have the same relevance. So the day and a half you're going to be here has been broken up into 5 different sessions. What we're trying to do is walk through each of the different aspects of prenatal genetic testing, how it's affecting the lives of women. And what we'll do is we'll have one key lecture, and then followed by an outstanding group of panelists who will provide commentary on that. Well, there's a formal structure to the symposium, and you'll see it there in the handout that you have. The real strength of the symposium is you, the speakers, the participants, the people that are here today. I encourage you to talk, collaborate, discuss the issues outside the structure of the symposium, whether it's at the lunches or the breaks, or as you go home when the conference has ended, still talk then. Use this chance to reestablish old relationships, perhaps a relationship you haven't visited since 1991. Forge new relationships, strengthen existing ones, so we can all continue these very important conversations as we go forward after the closing of the symposium tomorrow. So we're fortunate to have such an outstanding panel of speakers, leaders in the field of genetics, ethics, medicine, law, and social science. It's truly an honor to be with these people here today, many of which were at the original conference in 1991, some of them who are just beginning their careers at their time and now are the leaders that are leading us, and future leaders who will take this field forward. So please, I encourage you, when you can, talk, enjoy the experience, share this time with them. So thank you so much for this opportunity. Welcome, and I'm going to turn the stage over soon to one of our key speakers.
They can't get me down. So I was thinking I would give the talk from here, would that be all right? Now, where did it go? It doesn't go down? It doesn't go down. So I thought I'd just sit here. It's okay. You know, I always try to come into a room, oh my goodness, there's a fellow I met last night. And I was telling, never mind. I always try to come into a room quietly and not make a scene. This is about the best. Okay. So I need to, do you know how to get this back?
She just moves over and does it from here.
I think so. I can, absolutely. I
back her up and then let her come over that way. She can actually do it from the middle of there. And I don't know if those mics are on.
Well, I have a mic here.
Oh, okay.
So we should, well, can you get her in here? I can walk in there, guys. Okay. Just put me over the way. Would you like to sit on a chair, right? There. Okay. I just saw it on there. Did you go inside a folder?
You sure give it away one?
Yeah. I swear to God, it's on that one. Are you sure you're not on this one? It's the wireless. Okay, I think this is on. Well, there we go. Okay. He's working on it. Is Karen Ruffin back there? Yes. That's on screen. Needs to be refreshed. There she is. She has a presentation. She wasn't sure which flash drive it was on, so we're locating it. Yeah, it's not it. It's this one. It's this one. Find my slide. Oh, that's not mine. Hard on it. I know they are. I know. I'm sure Rona Hawk's in it.
Got it? Once you open it,
No problem. Let me take this one. Yeah.
open it for me and start.
I think it is on. There they are. Okay. Do you need someone to advance it for you?
Forward and back.
There's a laser pointer too. I don't know if you'll need it, but forward and back, you should be all set.
Like this. I'm ready if you're ready.
All right, thank you so much. I'd like to change gears just for a minute and recognize one of our speakers here today. It's with great pleasure that I introduce Elizabeth Thompson. Leader in field of genetics and mentor, she has touched so many lives over the span of her career. So many of us are indebted for her passion and dedication to the field. I met Elizabeth for the first time several years ago. During a visit to her office at the NIH, I brought this book. This was the book from the original conference. I sat in her office and I said, this was a great conference. Someone should do this one day. Well, I think you know what her answer was, and so we are all here today. Elizabeth came to the LC program over 20 years ago in 1993 on a detail from the NICHD, and she's been looking after the details ever since. The precedent-setting details of managing a new research program at the NIH, bringing in people from different disciplines and academic cultures to discuss genetics, and the paradigm-shifting details of protecting the interests of human participants in the scientific work of the National Human Genome Research Institute. All of that detailed work has led to critical changes in the field that have been instrumental in moving this whole field forward. She was instrumental in launching what is now an international discussion on the ethical and governance issues of stored tissue research. She's overseen the clinical studies of genetic testing for cystic fibrosis, colon cancer, breast cancer, and hemochromatosis, all efforts that have set today's practice standards. And she's been formative in establishing the Centers for Excellence in LC Research, also known as CEERS, which we have here in Cleveland. And with Karen Rothenberg, she organized NIH's first conference on women and genetic testing. It's only fitting that Elizabeth should give us our first presentation. So I'd like to take a moment first and thank her for all of her hard work, recognize what she's done for us, for the field, and wish her well as she changes her career path over the coming months. Thank you so much.
Thank you. Thank you so much. Oh my goodness. Thank you. Well, my goodness, I am so delighted to be here. And for some reason, Karen, I'm sorry, I thought this started at 1 and not at 12. So there you go. My schedule never is exactly right. That's probably one of the reasons that I'm moving on now to a new pathway. So what a delight that years ago Ruth came to my office and we sat down and talked. I guess you knew that I was co-editor of that book. What she failed to show you was the original book, which they published without Karen or I seeing the cover. And if any of you ever saw this cover of the hardback, it's really ugly. My mother-in-law, who is well known to not ever say anything bad about anybody, in her later years went to church with a woman, and there was a minister there speaking that day, and she leaned over to the friend and said, "My, he's a homely man." And that sort of reflects how I feel about this cover of this book. But in between the covers are really some wonderful words from some wonderful people. And it is, of course, now out of print, but for a few dollars, I might have a few left. Anyway, and of course, then it did have a second printing. And they did a paperback. And now this was a book on women's issues. And of course, they chose to put a fetus on the cover, which was an interesting choice on their part. And I've recently realized why it is that some people read books upside down and backwards. It's written in Japanese. It was actually translated into Japanese. This, of course, made both Karen and I quite wealthy in the time. We will tell you about our income from that outside activity. Anyway, that's not, I guess, how. So what a pleasure for me to be here today, and I really apologize for this grand entrance. I do truly try to enter rooms quietly, but it seems not to be possible if you have a walker or a wheelchair. It is simply not possible to quietly come into a room. So here I am, and thrilled to talk a little bit about women and prenatal testing. In my thinking that this was going to be presented at 1:30, not 12:30, I actually had a few other thoughts that I was going to put. I have a blank slide in here, and I'm going to tell you what I was going to put on that blank slide, okay, because I didn't quite get it in there. Now, if I can figure out this forward and backward. Yes. So, 1991. I told Karen I was going to put a few things about who knew in 1991, I mean, my goodness, who knew that in 91, Karen Rothenberg, young East Coast city girl and law faculty, would meet Elizabeth Thompson, Midwest dairy farm girl, nurse, genetic counselor, that we would arrive at the same place at the same time on IPAs. And what an amazing ride we've had since then. The two, we had come from really different worlds and yet felt sort of like we were kindred spirits. And in fact, we had a lot of overlapping interests and experiences and concerns about women's issues in prenatal, in the perinatal setting. Let's see if I can get this the right way. There. Okay. So I came to this position. Oh, wait a minute. I skipped a slide here. Did I already talk about that one? Karen who? That Karen, yeah, she wants me. I said she would go on to become a famous dean at the University of Maryland Law School, and the first woman with the distinction of holding this position in the 185-year history of the organization. That Karen would become one of Elsie's biggest critics and one of the most preeminent fans of the Elsie program. At least I hope she still is. And finally, that this all happened after she told me in 1991 that it was just boring, this genetic stuff. She'd say, these are not new issues. She'd be like, ugh, genetics, it's so boring. Nothing new, ho-hum. And from there, here we have Karen. So, I came to this situation having been a nurse. I was primarily a nurse in labor and delivery, OB nurse, taught OB. We had survived the time, and I say we had survived, but it really was the women had survived the time when physicians were still inducing twilight sleep. Some of you are OBs around here, I think. I saw Deborah earlier, Deborah Driscoll. There are some OBs who might remember twilight sleep. These were women who were given atropine, scopolamine, and Demerol while they were laboring. And they also had enemas and rectal examinations. So we wanted, for completeness sake, I would tell you lawyers to know what all poor women had when they were having babies. We quickly learned that we needed to keep the changing room for physicians that was backed by the delivery room. We had to keep it well stocked. Otherwise, the physician, they would, it was a different time then. They would come to the delivery room without pants on if there were no pants to put on. I mean, it's hard for you all to believe who are new, but you had to keep it stocked. I wrote men weren't allowed in the delivery room. Husbands were not allowed in the delivery room when I started in OB. Husbands were not allowed, and certainly not partners. Oh my goodness, no, not partners. And physicians actually threatened to quit OB if men were ever allowed in the delivery room, because they just said it'd be too much trouble. They'd have 2 patients, not 1, 3 patients instead of 2. IV alcohol, and I was shocked to learn one day when Ruth and I were sitting in my office chatting, Ruth didn't learn that we used IV alcohol to stop labor, stop preterm labor. And you know, it started out that we used IV alcohol, just give people a liter for over an hour. Of course, women got very drunk and very sick, very, very sick. And so you'd give them a liter and hope that the labor stopped, and usually it did stop. Of course, the woman was passed out. And sometimes it would restart, and then we'd give more IV alcohol, and that would slow things down. And, you know, in a day or so, day or two, it would stop or it'd go. And that was it. Got to a point where we thought it worked pretty well, so we would send women home sometimes and tell them to drink morning, noon, and night. So that's the kind of advice we were giving to people. And Deborah and I were talking about it this morning till like the mid-'70s. I mean, fetal alcohol syndrome, of course, was described in '72 in this country, and it was the mid-'70s, late '70s before people, I stopped, but before some physicians stopped using this method. We also learned very quickly that new residents needed urgent instruction on what women sound like when they are run up, and I mean literally run up in a wheelchair from the ER to the DR, the emergency room, to the delivery room, while pushing. And this, we had to teach the residents that this was a time when introductions were not necessary and family history was not necessary. We had to go back to the delivery room, period. Have a baby. And then I learned probably one of the most important facts that I ever learned in OB was that pregnancy, labor, and delivery are normal human physiological processes, sometimes complicated by doctors and nurses. And I learned that from a fellow I worked with in Iowa. I also came as a board-certified genetic counselor of 17 years by this time. I sound very old, I know. It's true, I am. But it used to be simple. Some of you started back in the 70s in genetics. You know, we talked to people about extra chromosomes, 13s, 21s, 18s. We talked to people about genes, dominant, recessive, and X-linked, 50%, 25%, 50% if it was a boy, and 25% if you didn't know the sex. Lots of time was spent with people where you knew a condition or didn't know a condition usually, and you gave them information as much as you could, and you did a lot of counseling. You talked to people about how they were doing, how their baby was doing, whether the baby was gaining weight, just how they were feeling. Then came things like introns. Introns. You remember, when I learned genetics, we didn't know about introns, or they were there, we just didn't know about introns and exons. They came in the mid to late 70s, were identified. We started to have banding patterns of chromosomes, and then we realized there were darker and lighter staining patterns of chromosomes, and that helped us to determine not just the number of chromosomes, but if there was a translocation, a relocation, an insertion, deletion. So it allowed us to see if there were chunks of genes that were missing or chunks of genes that were extra. And all of you must remember the wonderful years of Bayesian analysis of a pedigree when we could bring a woman's risk from 50% to 48.5%. And this would be after we had done blood tests and calculations with formulas, and we were able to tell women that their risk was 0.5% different than we thought it was, or so. And of course then there were markers and linkage analysis and recombination and RIFLIPs. Remember Rifflips for LOD scores? Those were the years that I thought, I'm quitting genetics because I cannot learn this stuff. That was about 80, 84, something like that. Yeah. But I stuck with it for a little while longer. Now, this was a slide that I was going to add a few things to, and I'll just tell you what I was going to add. You know, we knew there were 46 chromosomes. That was good. That was discovered in 1956. We thought there were somewhere between 40 and 100,000 genes in human beings, and now we know there's somewhere around 22,000 or so genes. I can't even read my own writing. Oh, we learned about one gene, one protein, one disease. Now we've learned about thousands of maybe one gene, maybe many genes, maybe thousands of genes, maybe thousands of mutations in thousands of genes. And it's not so clear-cut, unfortunately, as we thought it might be one day. So taking together these experiences of what we knew and what we know now, I mean, we now know that women were then and are still passionate about having babies. And women take the responsibility, especially if the baby isn't perfect. Women are likely to believe that it is probably their fault, although they might spread the blame around, but mostly they take it upon themselves. We learned early on in the 80s that the biggest predictor of whether a woman had a prenatal test or not was whether her husband wanted her to or not. The same study showed that the biggest predictor of whether a man thought a woman should have prenatal testing was whether they had health insurance. Very interesting about cost, I think. There were even some women who thought that they had caused their baby's birth defect. And they sometimes thought they caused their baby's birth defect because they hadn't had the test. Believe it or not, there are women who had babies who had a birth defect. One of the last counseling sessions that I did was with a woman who had had a baby with a neural tube defect. It was a very severe anencephaly type of birth defect, and she had been asked over and over and over by the health professionals, doctors, nurses, everybody, oh, you didn't have that blood test. And she said something in clinic that made me think, she said something that made me think she thought that had something to do with her baby having the birth defect. So I took her to a separate room and I said, now, you do realize that this baby would have had that birth defect if they had done the birth, and she didn't. She burst into tears. She did not know that. She thought that her baby developed that birth defect after she had not had that test. And there were other women similarly affected by the test that they didn't have. Any woman who had a baby with trisomy 21 was asked over and over and over and over, oh, you didn't have, if she was 35 or older, you didn't have prenatal testing? Are you sure you don't want to have prenatal testing? You know, and so forth. So that's what the women related at that time. So then, in addition to this history and this experience, along came Molly. I made up her name, Molly. But that's actually in the beginning of this book. I talk about Molly. I have Molly's permission to talk about her. Molly was referred to me, not referred to me, she actually, Gil Hill, who both Karen and I worked with at Child Health, came to me one day and he said, I have a woman friend who's pregnant and this is a really desired pregnancy, and her doctor has scheduled her for an abortion, and she doesn't want to have an abortion. And I said, what? I didn't understand. So I thought, well, will you talk to her? And so I made a date to have lunch with her one day, and we had a long and interesting relationship during that pregnancy. it turned out that she was a single woman. This was a desired pregnancy, a very much planned pregnancy. She had been trying to have a baby for a long time. She had become pregnant through IVF. And from day one, the infertility specialist started testing HCG and ultrasound, how big the embryo was. Week 1, HCG was low, and the ultrasound was, quote, lagging behind. Week 2, ultrasound, the embryo was lagging behind. The HCG was low. Week 3, week 4, week 5, the same thing every week. The embryo was small, and the HCG was low. By week 6, the infertility specialist said, this is not working, this is not normal. You need to have an abortion. We'll try again. And to her, it just felt like, you created this baby, now we're going to go do another one, because this one isn't working. Called my old friend who ran the OB program at Iowa, and I said, now, what does this exactly mean that the HCG is low? What would you tell a woman who was lagging behind in growth in HCG? And she said, I'd tell her that's not very good news. We would rather have it not lagging behind. Sounds to me like there's a risk for her to have a miscarriage. And I thought, well, is that worse than an abortion? And I thought, maybe not. So imagine, I actually talked to her and I said, she was scheduled for her abortion, by the way, at 8 weeks by her doctor. And she didn't want to go. And I said, well, go to your doctor and say, how would it be if we just wait and see a little bit longer, see what happens? And that made me very nervous, let me tell you, to suggest that anybody wait and see. I mean, something may be really wrong here. But she went to her doctor and said, can I just wait and see? I mean, might I have a miscarriage? Yeah, maybe. So she decided to wait and see, and then finally at about 10 weeks, she decided she wanted a second opinion. And her second opinion was not with an infertility specialist, but with a maternal fetal medicine person, who she said was like night and day. She was treated by an infertility specialist who behaved as if he had created this embryo and it wasn't normal, so we were going to create another one. Where the maternal fetal medicine person actually treated her as if she was a pregnant woman with a baby. And I've heard that again from many women individually that made me think a lot about what happened to women during this period. So I think that's one thing to sort of keep in mind. I will say that in the book, as I tell you, she went on to have a baby that, as best anyone can tell, that baby was normal. The baby did lag behind with HCGs and size, and she's not a very big person, and she had a littler than average baby. But for all intents purposes, the baby was okay. And when I talked to her about 2 years later, and honestly, I don't know where she is now, but I'd love to know what happened, because 2 years later, and this whole, I left out the part where we went through the abortion schedule, and then she decided to have MSAFP. It came back abnormal. She had AFP through amniotic fluid, and it came back abnormal, and then the lab called and said they made a mistake, and it was actually normal. And she had chorionic villi sampling also before that, that's right. The bottom line is she had a baby that appeared to be normal at birth, and it's an anecdote, absolutely an anecdote. We can all talk about anecdotes. But I thought about really in all honesty, pardon the word, but the hell that woman had been through during that several month period, 5, 6 months. And 2 years later, when I talked to her, her little boy was 2 at that point, and she was thinking of having another baby. And I thought, oof, the resilience of women. It's amazing. It's amazing, the resilience of women. So, what were we thinking? Is that the right line? Yes. What were we thinking? that Karen and I thought we could be bold enough. And by the way, Karen has her own stories to tell you, and I'm sure maybe she will later on or now if you'd like. In fact, before we go to the last slide, would you like to say a few things about what on earth we were thinking at that time?
You keep going.
Okay.
You're doing a great job.
For being late, I know. Well, so we were thinking that we could be bold enough to have a meeting on women and prenatal testing on federal property. And even mention the A word, but only if we had to and only once in a while. But we got permission. I mean, we in fact got, Dr. Alexander said, it's okay. You can say the A word. It's all right. That an NIH meeting, it would be unusual, and please read here, never done, okay, to have 25 of 27 participants around the table be women. And we tried really hard to look at women of color and women with disabilities. And finally, that the brightest and best women that we could think of in the world should be invited to the table to address women's issues. Not men, pardon me, my phone is now going off if anybody hears it buzzing. That women should talk about women's issues, which is quite a contrast from what sometimes we see. If you ever watched Saturday Night Live, they had a group of men on one panel looking at women's issues one night, and that was quite an interesting panel, if you can imagine. But I think I've seen that lately, haven't I? A bunch of men. Anyway, 20, yeah. But Tony, we decided, first of all, that we were audacious, if you'll pardon the use of that word, audacious enough to think that we could invite who we wanted, and they would come. We also said we are going to invite the people, and if they can't come, we will invite other people. We are not inviting people to send someone for them. And we are inviting people that will stay for the full 3 days. And we made people stay and talk and think. And if they couldn't be there for the 3 days, they couldn't come. And we did end up with 2 men. One was sort of the technology guy, we'll say. I think I'll say that. And the other one, of course, was a fellow that was active in the ELSI program, Tony Holtzman at the time. And we only let men come who were to this meeting who were sensitive. Now, I judge that. Sensitive men. Now, I want you all to think about this.
One or two exceptions.
Yeah. I said one was a technology.
But they were silenced soon enough.
Yeah, they were beaten into submission, right. I said one was a technology guy, if you remember. So now, I said sensitive, men could only be invited if they were sensitive guys. So, and I judge that based on how you put your toilet paper on your toilet roll. I want you to think about this, every one of you, for just a moment. I've done an unscientific poll my entire life, and I find that women go over and men go under. And the exceptions are sensitive men go over the toilet paper roll, and not so sensitive women go under. And there are a few exceptions, but think, how many of you agree with me on this? How many women put their toilet paper? Well, from now on you will, and you will find that women generally put the toilet paper over. So that is the end of what I probably should say for the moment. But I want to say to you that this was sort of the first meeting of a set of wonderful experiences, and I've had 20 years of wonderful fun, and I hope to see you many, many years forward from now, but I'm not going to be as one of the leaders of the ELSI program, but in a few months I'm hoping to be retiring to Iowa, not Ohio and not Idaho, but Iowa. We grow corn and soybeans and all that we feed the world, right? Some way. So anyway, I thank you all of you researchers for my time with you, and all of the rest of you that I don't know, I hope to meet, and I'll finish with that. Thank you very much. And I apologize for the loud entrance. commotion.
Can you take the steps down to that chair? Do you want to sit in the audience for that? So that I think she can sit right there.
Wonderful.
Okay, that's
So
fine.
I'm gonna.
Let's get a actually,
Is there a chair close to the front that I?
yeah,
might
we'll
get-
get you a chair right there.
I would even go a step or two if I could have a corner of the table.
Yeah, we can do that.
Who's next to that person? Oh, there's Ruth sitting. Oh, you have to sit in
I
her
can
chair.
give you my chair over
I
there.
will leave you this, and if you would bring this for me, I will. I didn't bring my walker because I didn't realize I would need it, but there you go.
It should be, is it not? There. Yes,
No problem. There you are?
Oh, okay.
I'm so sorry.
Oh, it's your water?
I would love it,
water?
yes,
So,
if I could,
okay.
you buy me some water. I'm gonna need the cane, so don't go far. I get there.
Forward, back. If you want a laser pointer, and you can move around with it, although don't try not to go too far from the mic.
She's going to sit where
You will have, that will show you your time as you're going to need help with the
I'm
hand.
gonna see if I can try to get up. Yeah. It's still fun being disabled.
you need to do anything for you or support you in your wages.
Oh, once I get up, I work better. Yeah, I'm sorry to be so slow. Okay. Once I get seated, I won't bother anybody.
All right, we're going to get started with session 1. The title of this session is Expanding Technology, Expanding Options. And it's with my pleasure to introduce Dr. Annie Lyerly, who will start us off on this session. Associate Director of the UNC Center for Bioethics, Associate Professor for the Social Medicine and OBGYN, and good friend. We'll get us started on this panel. She'll start to give us some background, some basic ideas from which we're going to start the rest of our conversations for the next day and a half. I'll have her come up and speak first. Then we've got a set of panelists. I'll invite them to come up later. We'll do the panel discussion and then open the floor for some questions. Annie.
Well, thank you, Ruth. It is such a huge pleasure and honor to be here. I want to begin by thanking both Ruth and Jessica for organizing a really spectacular day and a half. I mean, the people they've brought together are simply an incredible bunch of people, and I'm simply delighted to be a part of them. I know this was years in the making. It's not months, but years in the making, so let's celebrate. I also want to acknowledge Karen Rothenberg and Elizabeth Thompson. As I was preparing my comments for this talk, I got to look at their amazing publication again. And it really was a groundbreaking effort that they had in 1991, because what they did was refocus public conversation, ethical debates, policy debates about prenatal testing where it needed to be, which was on the health and lives of women themselves. I mean, it's pretty amazing that there's a fetus on the front of their book, because that's exactly the sort of myopia that the entire book works to redress. So it's a, irony, right? But when I think about moving forward, I first thought, well, we are really standing on the shoulders of giants, but so many of those giants are here in the room. I like the analogy better that we're holding the hands of giants. So let's move along with that analogy. So expanding technology, expanding options. What I thought I would do today with very broad brushstrokes is try to set the stage in some ways for our conversations today. And I'm going to talk about 3 ways in which technology has expanded since 1991. One expansion is with regard to who is offered testing. Another is how are they tested? And another expansion is what is being tested for. I'll talk about the ethical implications of each of these expansions, and I mean really just touch on them because I think we're going to get into them later. But as you'll see as my talk goes along, some of the concerns have been addressed, so I think there's been some progress, but other concerns have emerged or amplified as the technology has expanded. I wanted to just remind us of the manifesto that was at the culmination of the work that was done in 1991. And what's striking about it, and Ruth mentioned this, is that many of the considerations that ought to guide advancing technologies that were identified 20 years ago are as relevant today as they were back then. And let me just quickly go through them. Prenatal testing ought to be for personal, not eugenic goals, and it's aimed at, as the authors said, increasing individuals' control over their reproductive lives. It needs to be meticulously voluntary. It can't be thrown in with other routine prenatal tests. It needs to be value sensitive. We need to pay attention to the variation that in values that women bring to the table when they think about making families. There has to be an emphasis on information, education, and counseling, not just an emphasis on the technical aspects of prenatal testing. Social and economic constraints need to be removed, and there is always the potential to stigmatize those with disabilities. So these are the considerations that they said we should keep in mind, and like I said, I think they're just as relevant today as they were 20 years ago. So let's begin with the first expansion. Who is offered testing? So I'm going to focus primarily on invasive testing. Historically, invasive testing for prenatal aneuploidy was directed at high-risk individuals. Diagnostic testing was for women who were either over 35 years old or had a positive screen, meaning that their risk of having a baby with Down syndrome or another chromosome abnormality was equal to or higher than that of a 35-year-old. Very recently, new guidelines have de-emphasized this age-based risk stratification, and in 2007, the American College of Obstetricians and Gynecologists made the following recommendation. They said invasive diagnostic testing for aneuploidy should be available to all women regardless of maternal age. This was a big shift. So we see expansion. One is that technology is expanding across risk strata. So what does this mean in terms of ethics? So in some ways, it's really a marker of progress. As our colleagues said in 1991, providers should be particularly sensitive to individual differences and similarities and adapt services accordingly. Now, if you look at the reason why 35 had been for years a cutoff, it was primarily because of a graph and a place on a graph where two things intersected, namely the risk of having a baby with a chromosome abnormality and the risk of losing a pregnancy because you have an amniocentesis, a risk of miscarriage from the procedure. So at at the point where those risks are equal to each other, the presumption was beyond that is reasonable to get an amniocentesis and risk loss, and before that is not. It presumed that women across the board value healthy loss and the birth of a child with Down syndrome equally. Well, it turns out, probably not surprisingly to a lot of you in the room, that studies of diverse populations indicate that preferences vary. Many women regard one or the other of those outcomes as catastrophic, but not the other, and women vary with regard to which outcome they so deem catastrophic. So there may be a 43-year-old who's had infertility for 6 years, and the idea of a healthy loss of a pregnancy that is highly desired and probably her last chance is unthinkable. Maybe for a 26-year-old who has 3 kids already and no partner, no family to help, having a baby with Down syndrome would be similarly catastrophic. In theory, both of those people would have a reason to or not to have prenatal testing. But if the 43-year-old said no, she would be deemed unreasonable, and if the 26-year-old said yes, she would be deemed to have an anxiety disorder. So the current approach attends to the variation in women's values. So it's progress, but there's problems too. It has the potential, and worries have been raised, that it could further stigmatize those with disabilities. We're going to test everybody for Down syndrome now. How do you think the Down syndrome community is thinking about that? It has the potential to challenge the idea of meticulously voluntary consent. If everybody should be offered the test, then it's just going to be thrown in the way AFP testing was done, which was blood testing for screening. And then there's the risks of implicature. So when a doctor offers you a test, there's often the presumption that they recommend it. So testing could be understood as the responsible thing to do, as it has been for women over 35-year-olds. And so more women could feel like they're responsible for the outcomes of their pregnancy, especially if they deliver a baby who's affected. This could be the story for everyone. This is a quote from Raina Rapp's beautiful book, Testing Women, Testing the Fetus. "My doctor was so angry with me. He couldn't believe I didn't take that test. You could let this happen," he yelled at me. "You're 40. This is a woman who had a baby with Down syndrome. So this is some unpublished data that we have I thought would be interesting to show. And this is 2009, how OBGYNs think about offering just a screening test for prenatal prenatal screening for aneuploidy. Which best describes your practice with regard to serum and ultrasound screening? So this is before invasive testing. 45% say they recommend it. 51% say they present the information but don't make a recommendation one way or the other. So they're pretty broadly split on what they understand their obligation to be. And so you could imagine that women who get this information also have different perceptions of what it means to accept or decline the test. Okay, so there are other problems. One is that age-based dichotomies are entrenched. So just ACOG changing policy is not going to change the way people do things. More unpublished data about amnio. We asked the same physicians, consider 4 scenarios: 25-year-old with positive screen, 25-year-old negative screen, 37-year-old positive screen, 37-year-old negative screen. And there are 3 people who would be very likely to be offered an amnio, and this is post-ACOG guidelines. 37-year-old regardless of what her screen-based risk of having a baby with Down syndrome is. So even if the 37-year-old now has a 1 in 400 chance, she still gets access to amnio. But the 25-year-old with a negative screen doesn't get it, still. Very unlikely. That's the orange bar. Okay. This is going to carry into the non-invasive testing realm. So I think some of my colleagues are going to talk later about what the more technical details of non-invasive testing, but what's rolling out is testing in the early part of pregnancy, which is non-invasive. And in the initial rollout of this testing, it was done on high-risk women who were over 35. So the people who are going to have access to testing are women who are high risk. But if you are low risk, if you're 25, but you really want to know whether you have a baby with Down syndrome, you're still going to have invasive testing. So the bottom line is that procedure-related miscarriage is undertaken, risk is going to be undertaken by women who are least likely to have an affected child. So that's a paradox right now. I think it's going to be redressed later, but it's one of the problems of the age-based testing. So let me move on to the question of how testing is done. So there's been expansions in terms of both timing and invasiveness of testing. Historically, testing was physically invasive mid-pregnancy, amniocentesis 15 to 20 weeks, and CVS greater than or equal to 9 or 10. Both are invasive, both carry a risk of procedure-related miscarriage. New technologies, though, allow non-invasive earlier testing. So what we're talking about is a blood test, a very accurate blood test that's done very early in pregnancy that can tell you whether or not, with some range of error, your fetus has a chromosome abnormality. So it's a blood test. There's no increased risk of loss, but presently there's a recommendation that positive tests be confirmed with amnio before pregnancy termination is decided upon, at least. Okay, so expansion number 2 is technology has allowed earlier non-invasive testing. This is kind of a busy slide, but I think it's sort of interestingly portrays where we have been and where we're going. So when I was in training, mostly we did prenatal screening with what we called a triple screen, so blood test kind of in the late first, early second trimester, and then if that screen was positive, we did an amniocentesis between 17 and 20 weeks. So that's how we used to do it. When I started practicing, nuchal translucency screening came up, so we combined blood tests and ultrasound and got a better idea, but you still needed an amnio later on to determine whether your baby was affected. And now what we're doing is we're moving way back early in gestation with these non-invasive blood tests. So how is this progress? Well, earlier, the presumption is that earlier testing is better. It answers some questions about fetal health earlier, and it shortens this explicitly tentative period where people, hide their pregnancies. They don't tell their friends. They don't post it on Facebook, although I've heard that some people do anyway, until they know for sure, until they get past a particular point. And this has the potential to shorten that period of time, which sociologist Barbara Katz-Rothman has described beautifully in a book as problematic. It also reduces the moral burden associated with later terminations for those who consider later abortion more serious, morally speaking. It also, if you can get your diagnosis earlier, it reduces the physical risk if a woman decides to terminate. It's also non-invasive, and I think this is a key issue. It eliminates for many the really, really problematic moral conundrum of introducing risk with invasive testing and the possibility of healthy loss. So there are many women that the possibility of healthy loss scares a lot, for good reason, and that is eliminated with this early testing. But there are problems. Is earlier really better? I mean, early losses are painful too. I, for several years, ran a miscarriage clinic. Most of the women that I took care of had losses of 8 weeks or less. And one of the hugest sources of pain for those women was the presumption among everyone, their doctors, their loved ones, their friends, that was because the loss happened so early on that it wasn't a big deal. So early loss is still painful. For some women, spontaneous loss that would happen maybe at 9 or 10 or 12 weeks would be replaced by an intentional termination of pregnancy. And while we're still requiring a confirmatory amnio or CVS, it lengthens the waiting period between a positive test and a confirmatory test. So some people might say that that's worse for women. Are there downsides to a test being non-invasive? I think we have to think about the downsides. One is that, you know, it's just a blood test, and it's procedurally simple, but it is not morally simple. And so the worry is that people are going to sign up for this blood test without thinking as thoroughly about it as they would have about an invasive test, which they had to provide informed consent because it their body was transgressed. And that's how we think about things in medicine. You have to sign this long form if I'm going to put a needle into a major part of your body, but if I take something out of your arm, not so much. You also lose this sort of gatekeeper effect, and some people have said that the possibility of loss, the possibility of healthy loss, makes people think really hard about the idea of prenatal testing before they have it. And if it were just a blood test, they wouldn't have to think as hard about that. I'm not sure about that critique, but I think it's worth talking about. Okay, third expansion, what is being tested for? So historically, what was tested for were serious or life-threatening conditions, sex-linked hereditary disease, aneuploidy neural tube defects. New technologies, the scope of testing is now potentially massive. Genome-wide analyses, we could potentially test for adult onset disorders. I meant to write adult onset, but also child onset, adult onset disorders, minor abnormalities, non-health related conditions, predispositions. So the third expansion is that technology allows testing for a wide breadth of conditions, traits, and predispositions. So how is this good? Well, more control, right? We say that reproductive genetic testing should be aimed at increasing individuals' control over their reproductive lives. More information may do this to a degree. If we have more information, we can terminate pregnancies that we might not have welcomed into our lives. We can make advanced plannings for those that we will. And there's always discussions about therapeutic interventions, even before birth. Maybe reduce stigma too. I mean, one of the problems with Down syndrome is there's so much attention to it with regard to prenatal diagnosis that there's a huge stigma with it. And if we spread out the testing over a vaster array of diseases, maybe you could spread out the stigma a little bit. Who knows? But there are a lot of problems, and I have like 3 slides worth of problems. I'm glad my blinker isn't blinking yet. But information doesn't necessarily enhance autonomy, health, well-being, satisfaction, and there's a lot of evidence with regard to this that I'm going to touch on. First of all, too much information can affect people's ability to choose, and behavioral economists have been chomping on this bone a lot in recent years. Some of you may have heard about the JAM study by a business professor at Columbia, and I'll just go through it. I spent the wee hours of last night while my 7-month-old was asleep next to me making these jam jars. Aren't they nice? So this business professor went to a grocery store, and one table had 24 jam jars, one table had 6 jam jars, and they were set out for people to come taste. So first what they did was they recorded how many people who were given a $1 off coupon for jam came to taste the jam. And perhaps not surprisingly, the table with the lots of jam jars had more people eating jam. But something very interesting happened after that. When it came to who was going to buy jam, those numbers switched and switched dramatically. The people who went to the 24-table jam jar, only 3% of the people who went to that table ended up buying jam. I mean, the green jam doesn't look that yummy, so maybe but the people who went to the table with 6 options, 30% of them bought jam. So there's a way in which, and this has started a conversation among, or fueled a conversation among behavioral economists and others, that the more choices we have doesn't necessarily make us better choosers. In fact, it can be paralyzing and can end up making us make decisions that are not in our best interest. So another problem is that too much information can lead to overdiagnosis and overtreatment. There was a really interesting study that was published last week in a major medical journal, I can't remember which one, but just showed that of all cancers detected by mammograms, 15 to 25% probably would have regressed on their own. How about that? Another thing is that when you do broad testing, you'll find soft or indeterminate findings, and if they don't really hurt you in the near term, they can last. I always tell the story of a good friend of mine who, clear-eyed, smart, Vassar graduate, amazing woman, called me in tears one day because she had just been told that her baby had cysts on its brain. This was her first pregnancy. And I said, Sally, hold on. This is not the end of the world. What did they tell you? She said, choroid plexus cysts. They said, my doctor's going to call me tomorrow. My baby has cysts on his brain. And I said, you know, if that's all there is, it's fine. There's no problem, Sally. I mean, she tried to believe me. I don't know that she did. Well, eventually that was the news that she got. This is a finding, if in isolation, is not problematic. So I thought once we'd resolved that, everything was fine. She delivered a gorgeous baby boy. 4 years later, we're in the park together. She's my childhood friend. Our children are playing with each other, and her little boy starts, singing the alphabet. And she said, see, Annie, those cysts on the brain were nothing. Lasts. What we see and what we hear and what we're told about our fetuses lasts for a long time. And finally, the interpretation of results are uncertain. So we don't know what a lot of this genetic information means. So if we think we should terminate a pregnancy because our baby has a predisposition for cancer, well, maybe it is that same predisposition for cancer means you have less of a disposition for autoimmune disease. We don't understand this stuff enough to even make recommendations about things. So too much information can lead to constrained choice, unnecessary or harmful intervention, a sick role, and relational shifts, like the one that happened with my friend and her baby. There's also can be a mismatch between findings and treatment options. So we can find things that are wrong with fetuses, but there may not be access to therapeutic care. There may not be therapeutic care, but there also may not be access to it. And we're at a time, all of us know, that there's a big threat of constrained access to abortion. I mean, when I was looking for images for my slides and wrote prenatal testing, images, whose face do you think came up? Yep, Rick Santorum. Also, there's the detection of late onset conditions. So do our future children have autonomy interests? They do. Do our children have interests in not knowing stuff, like whether they're going to have Huntington's or breast cancer when they get older? Should that be their decision to find out? And then when we test our fetuses, we test ourselves. Testing a fetus can mean that we detect maternal or paternal disease or predisposition. Okay, so just to summarize, there's been 3 expansions over the last 20 years. The first one, technology has been expanding across risk strata. The second one is that technology allows earlier, non-invasive testing. And the third is that technology allows testing for a wide breadth of conditions, traits, and predispositions. So I'm just going to conclude with a few thoughts. And again, these were thoughts that I kind of put down as my baby was starting to wake up. So I've actually Not sure what's going to come up, but I hope I can. So seriously, expanding technology brings some solutions, but enduring challenges and new challenges as well. The ethical considerations, the ones that were brought up in 1991, remain relatively constant, but there are new ones to consider and maybe some new ways to consider them. So one of the questions is reproductive control really what we're after? I mean, after all, we really can't control the sorts of children that we have. It's never in our control. So is that really what we should be aiming for? Because there is a sharp side of that, I'm mixing metaphors, but there's a problem. If we think that we have control and things don't turn out well, somebody is to blame, and women do still very often blame themselves. Given the volume of information, how do we filter this mass of information versus accommodate the diversity of preferences people have for that information? Is there a role for behavioral economics? I think there is. And where are the moral frameworks that many of the participants in the conference 20 years ago said we needed for pregnancy, the ethics of parenting that resonate with women's experience, that call attention to relational issues, that call attention to context and particularity? We still need those frameworks to be articulated. Keeping women's values and lives at the center is key. Thank you very much.
I'd like to invite our panelists to join us up at the front here. We have Dr. Deborah Driscoll, obstetrician and geneticist, professor and chair of Department of OBGYN at the University of Pennsylvania. Professor Jaime King, associate professor of law at UC Hastings and associate director of UCSF UC Hastings Consortium of Law, Science, and Health Policy. Dr. Michelle McGowan, assistant professor of bioethics at Case Western Reserve University. And Dr. Eric Juengst, director of the UNC Center for Bioethics and professor in the Department of Social Medicine. So each of our speakers will have up to 10 minutes to talk. Some may give presentations, some may just speak from back here. And then we'll open up the discussion or open up the floor for any discussions. Thank you. When it comes time to questions, please keep in mind, we'd like you to come down and speak in the microphones. That way we can record the question. Excuse me. I'll turn this over to you. Absolutely.
Well, first of all, I want to thank Ruth and Jessica. It's really a privilege to be here, and I'm very much looking forward to the discussion. And I'm going to build on what Anne was just talking about. And as a practicing obstetrician geneticist, I'm going to get really practical here. I'm going to share with you some of the practical issues and counseling challenges that we are facing every day in practice. And I hope that the cases that I've brought today will illustrate those challenges. I've also posed a lot of questions for us to consider in the discussion, as well as taken the liberty of making some recommendations. I'm going to comment on non-invasive fetal DNA screening for aneuploidy very briefly, because I think it's very timely, and again, it builds on what Anne just talked about. And then I'm going to focus on chromosomal microarrays. So in the past few months, there has been a big marketing campaign, a lot in the press about the non-invasive DNA screening. It has a very high sensitivity. It has been validated in a high-risk population, and there is a big push for practices to offer it. But we are facing a challenge in getting this introduced into practice. Why? Well, there's the demand, but there's limited availability. You heard, it's really for high-risk patients. But that just really goes against what the ACOG guidelines recommended several years ago, which is that screening should be available to any woman. It shouldn't matter whether you're 25, 35, or 40. And in fact, you should decide whether it's a non-invasive screening test or an invasive test. Patient autonomy, patient preferences. And so this is really, in my mind, a step backwards to, and it's forcing some women to select a test which is less sensitive and could push them towards multiple tests. So in other words, they could have a screening test, the traditional serum screening test, it comes back positive, then they have another test and another. And so it's that roller coaster that we see that can be so devastating in a pregnancy. So we're having to make a lot of adjustments to what I call our consumer preferences. And it is really difficult right now because this is an out-of-pocket cost for patients. So again, it's restricting access to an excellent test. I take care of patients who are on Medicaid. I also take care of patients who come from very high socioeconomic groups and can afford this test. But if you have to pay $400 or $200 for a test, you know, it may not be something you can afford. So these are issues that we must address on the practice side. And for patients, again, it's causing confusion, anxiety, and mistrust. And so many patients come in and say, I want it all. They don't understand, and they're getting mixed messages. So we have a lot of work to do. And I think that the companies that are marketing these tests didn't partner with us. They didn't allow us the time to prepare and think about how we were going to offer this test, to prepare educational materials for our referring providers, for our patients. And so it's been quite simply a mess. And now we are trying to work this out. This is a quote that came in an email to one of my colleagues yesterday afternoon when we were seeing patients. And this patient says, from what I understand, I should feel very good with the negative maternity T21 test, but I think that positive screen will haunt me until birth. Exactly like the CP-CIS. They can't let go of that result. So with regards to aneuploidy screening, our professional organizations need to look at the evidence. We need to look at the social and ethical implications that we're going to talk about, and we need to develop some optimal screening strategies, some best practices. We need professional guidelines. Offering tests without some kind of infrastructure based on the evidence and based on what's practical doesn't work. We need to enhance our communication with labs. We need to reduce the costs. We need to make this test available. And we need to think about whether this might be the best test and whether we can let go of other screening strategies and make this be the most cost-effective test. Because if the patient wants this screening test to begin with, and I agree about informed consent, we've got to deal with this issue, then let's let them have the best test, the test with the lowest false positive test, the test that has the highest detection rates. I think there's a lot of opportunity here to look at patient preferences and also to evaluate the role of non-invasive screening tests in the evaluation of the fetus with sonographic abnormalities. And what I'm often seeing now is patient comes in with a cystic hygroma or an increased nuchal translucency. Are we going to do a non-invasive test or are we going to do a CVS? What does the patient want? What does the provider think? I mean, we need to get some clarity around these issues. Now I'm going to change gears a bit. And before I do that, I just want to say the reason why I think it's important to think about non-invasive screening is, while it's non-invasive screening today for aneuploidy, it could be expanded in the near future to include screening for other genomic imbalances, for example, or mutations. So we have to think about how we use non-invasive screening in general. I'm going to focus on chromosomal microarrays. The NICHD funded a prenatal microarray study. It ended in late 2011. Dr. Pergamon is here, and he and I were members of the advisory committee to this study. And the goal of this study was to evaluate the performance of microarrays compared to conventional cytogenetics. And it was a multi-center study, prospective, and over 4,400 women were enrolled. These women were having either CVS or amniocentesis for advanced maternal age, sonographic abnormalities, positive serum screening tests. And anytime there was a test result that was rare, maybe never seen before, or of equivocal significance, uncertain clinical significance, we had a conference call with about 6 to 8 geneticists or genetic counselors, and we talked about the finding. And I have selected several cases that we discussed to illustrate some of the challenges that we faced. And I'm going to tell you from the start, put 8 of us on a conference call, and I can tell you we didn't always agree. And these are geneticists. So just think about it. If this goes live and obstetricians are receiving these test reports, or geneticists that haven't had training in how to interpret microarrays, what does it mean? What does it mean for the patient? So, case number 1 is a 28-year-old woman who had an ultrasound done that showed a unilateral club foot. An amniocentesis was performed and the karyotype was normal. A microarray was performed and it demonstrated a duplication in chromosome 7, on the long arm of chromosome 7. It was about 1.4 megabases. So we were asked to consider this result. Well, what we do is we look at the literature, we look at databases, we say, how many cases are out there? And what did we find? We found in this case, 14 cases had been reported of a similar duplication, and what we also find is that the phenotype is highly variable. And in fact, in 40% of these cases, these were inherited duplications. A parent had the same duplication. We found that some of these individuals have normal IQ, but 80% have mild to moderate retardation. There was 40% had autism. So one of the challenges for us is that there is variable expression and incomplete penetrance. And so there is uncertainty in our counseling. We cannot accurately predict the outcome. But in this case, this variant, the evidence was significant enough that we felt that it was a pathogenic variant and should be reported. But we also know that a lot of the information that we're relying on comes from the pediatric population, and there is some ascertainment bias. This second case is a CVS that was done because a previous child had severe developmental delay and had a duplication, so the parents wanted reassurance. And in this case, a microarray showed another duplication, but we found no similar cases. And when we looked in the literature, there were, and we looked in databases, we found that there were genes in this region, but they didn't appear to be particularly significant. And so we asked the question, should this be disclosed to the parents? I'm going to do one final slide because I know I'm running out of time. So one of the things that we have to discuss and think about is, do or should labs report every variant they find? How do we deal with these insignificant or potentially benign variants or variants that are of uncertain clinical significance? These can be misinterpreted, and they could potentially cause harm if they are not appropriately communicated to the parents in a very sensitive way, and that parents understand what this means. And there's a lot of debate out there about disclosure of lab results. And so we have to think about not overwhelming parents with information that may not be significant, minimizing the distress in a pregnancy, and perhaps even apprehension about the future as they look at that child. So I'm going to stop there because I know because of time, and then if we have time later, I may pull up some of the other cases. Great.
Thank you so much. Professor King? Let's get you up here. Right here? Mm-hmm.
Hi, well, I'm going to take my brief amount of time to discuss the impact of recent advances in reproductive genetic testing, the impact that these will have on choice. And I'm going to do this a little bit from a legal perspective. As a lawyer, that's where I tend to come at these issues from. But I'm going to discuss choice in 3 realms. So choice in the selection of tests, choice in informed consent and the kind of choices that women are going to make with respect to their prenatal care, and then finally choice in the realm of reproductive rights. So let's start with selection of tests. We're going to have to start thinking very carefully about how do we choose the tests we're going to offer, and who is going to make these choices. So the FDA has not established a concrete approval process overseeing genetic tests as a whole, let alone what kinds of tests are appropriate in the prenatal context. And so in the absence of some kind of approval process and thinking about what's an appropriate level of validity to offer in the prenatal context, a lot of this decision making is going to be put into the laps of physicians and genetic counselors. And so a lot of obstetricians haven't had extensive training in genetics, and they oftentimes don't have the time to consider the analytic validity, the clinical validity, and the clinical utility of every kind of test. And so as you've heard from Anne and Deborah before, the number of tests that we're going to be able to offer and the kinds of conditions that we're going to be able to examine are going to expand pretty significantly in the near future. And so you're not just talking about the clinical validity of one test. How well does this particular Down syndrome test go? You're going to have to look at it across a whole range of conditions. And what I think is more likely than a lot of physicians doing this on their own is biotechnology companies are going to do it for them. They're going to tell you by grouping different tests together on different kind of panels, offer these tests together. Offer maternity 21, which is going to be maternity 21, or maternity 21 plus, which is going to include trisomy 13, trisomy 18. Oh, into the mic more. Okay, I tend to wander, sorry. But anyway, so I think they're going to make these choices for us, and they're going to market those tests to physicians and in some cases directly to patients. And so we need to have from the clinical community and from the bioethics community and the patient community some kind of response of what kinds of tests do you want to see, do you think are appropriate. The next question that I want to examine is current prenatal screening, the informed consent protocol. One of the things that's going to happen with non-invasive prenatal testing is we're going to move from our current model of you're offered screening. A lot of women just go ahead and have the prenatal blood test screening tests. And it's only once they screen high risk that they actually get a more intense informed consent process, where whether they get it through their obstetrician or they get it from a genetic counselor, but they get in-depth information about the specific disease or disorder they've tested high risk for. And then they are asked to compare that with their personal values, how they feel about a risk of a potential pregnancy loss associated with amniocentesis versus the benefit of that information. But NIPD is really going to compress that down to a one-step process. Even if you're finding near diagnostic, even if that test is not diagnostic and they want you to follow up with an amnio, you're going to be getting near diagnostic information. So obstetricians are going to have to find a way to get all of this information to women in a one-shot deal. Do you want this blood test? It's going to potentially tell you information about a range of genetic and chromosomal conditions. How are they going to provide that amount of information across a range of conditions in one setting? It's going to be a big challenge for informed consent across the board. The next question that is brought up is the fact, because NIPD is non-invasive and it reduces that risk of miscarriage, it's likely to create a much greater pressure on physicians to encourage testing, but also on women to accept. If you don't have that risk, as Anne said earlier, it doesn't serve that gatekeeper function, right? There isn't a risk to fall back on and say, well, I didn't want to risk the baby at all, because a lot of times women will say that if they just don't want the information. But now there is that pressure of, well, there's no risk. Why wouldn't you find that information? All information, the benefit of even unreliable information might seem to overcome the risk of a simple blood test. And as more women test, the pressure on additional women, everyone going through it, is to test and test and test. The third thing is that NIPD offers this information at a time in the pregnancy that I like to determine or call more actionable. And what I mean about this is that, I think I can do this. You can see that the current screening timeline puts you at, you have a first trimester blood draw between about 10 and 13 weeks, an ultrasound between 11 and a half and 14 weeks, and then a second trimester blood draw. That's the screening protocol. But NIPD is going to push all of this so much earlier into the pregnancy, which is going to do a bunch of things for women, especially even from a legal perspective. It's going to give them a lot more time to think about how a child with a disability or disorder would impact their life. They could meet with families. They could talk to them about what life with an affected child is like. And they could learn about resources available to them in the community. This is an incredibly positive thing with respect to reproductive autonomy and reproductive rights. This is especially true given that we now have states passing laws that are moving the time period for abortion earlier and earlier. We know that Nebraska has banned abortions beyond 20 weeks on the basis of fetal pain, and the Arizona state legislature just passed earlier this week a ban beyond 18 weeks. The governor still hasn't signed that bill, but if you're trying to get in after 15 weeks, your blood draw, and then go through genetic counseling to decide if you want an amniocentesis, schedule it, have it, get the results back, and you can't have an abortion beyond 18 weeks, we're starting to really put pressure on women's abilities to make thoughtful and rational decisions. The other part of this more actionable time frame is for women who decide that they do want to terminate, there is the option potentially of a pharmaceutical abortion up until 10 weeks. Surgical abortions are safer and easier for them in this earlier time period. And it is, for better or for worse, a more private time in the pregnancy. And this more private time may cause women to think about their pregnancies differently. Every pregnancy may become contingent upon hearing a heartbeat at 8 weeks and getting the results back of that NIPD scan, of that NIPD test, right? That may be the moment where people feel more comfortable telling, and it may push us. I think decisions about termination may be very different for women at 8 or 9 or 10 weeks than they are at 20 weeks. And so I think it's going to be important for us to think about that. The final thing that I want to bring up is how NIPD and the opportunities and choices that women are going to have with respect to prenatal testing may change reproductive rights overall. Without question, offering women significantly more information about their fetuses at an earlier point in pregnancy is going to necessarily expand their reproductive autonomy. They're going to have more knowledge about more conditions and be able to make choices. But as we heard earlier, maybe more information isn't always the best thing. Maybe it constrains our choices or can cause some form of paralysis. The other part of this is that genetics isn't as neat as it used to be. It's not just a positive or negative test. Some of these things will be predispositions. They will be risks and chances. And our ability to communicate risk information effectively to people and people to understand statistics is going to put in a great deal of pressure on our informed consent process. The other thing that's happening as this technology is moving forward is states are starting to constrain reproductive rights from a number of different angles. I mentioned before how abortion timelines have gotten earlier, but now we're also seeing states start to constrain the ability to access abortions sought for certain reasons. So we've seen 4 states that have passed laws restricting a provider's ability to provide what they know is a sex-selective abortion. Other states have expanded that to include race, and there are a number of pro-life groups that are trying to expand that to all all genetic disorders. And so as a result from that, states are really trying to push on the boundaries of reproductive autonomy. We're also seeing states pass wrongful birth prohibitions, which would protect providers from tort lawsuits when they knowingly withhold information from women that they think might cause them to have an abortion. So the questions that I want to leave you with are these. As the range of things that women can decide to abort for expand, does a woman still have a right to abort for any reason, including any possible genetic reason? And does that right necessarily entail her ability to access diagnostic genetic tests to inform that decision? And is that any technologically feasible genetic test? Or do states have the ability to come in and constrain the reasons why women seek abortions, the tests that they have access to? And then finally, are there instances where states should have that ability? Are there points where state interests rise above that? And so I think with that, I'm out of time, but I thank you for your attention.
And now we'll hear from Dr. McGowan.
Okay, thank you very much to the organizers of this symposium for inviting me, and for the previous speakers in this session for setting me up nicely for what I'd like to say. So I will be talking today about expanded carrier screening as a new form of prenatal screening that we might consider to address the question of whether or not expanding technological capacity actually expands women's options in the context of pregnancy. So for those of you who are not familiar, expanded carrier screening, I will use this definition and the abbreviation of ECS going forward. ECS is a carrier screening tool that individuals or couples can use to inform reproductive decisions, which evaluates recessive mutations in multiple genes to estimate the likelihood of a future child being born with a recessive genetic condition. So far, this has been marketed as a screening mechanism that is universal in scope, rather than targeted towards any specific racial or ethnic population. And this is notable because the current landscape for carrier screening is much more limited than this universal declaration that we see from the new products that are available. Current carrier screening recommendations at the population level are typically limited to cystic fibrosis carrier screening, which has been recommended both by the American College of Obstetrics and Gynecology and the American College of Medical Genetics. The American College of Medical Genetics has also recommended population-wide spinal muscular atrophy screening, carrier screening, and certain racial and ethnic populations, particularly the Ashkenazi population, has been recommended certain forms of carrier screening for recessive diseases that are more common in the Ashkenazi population. Women may also be recommended for carrier screening if there's a known family history of a specific genetic disorder, for example, Fragile X syndrome. So expanded carrier screening is a departure in many ways from the existing landscape of carrier screening tools. ECS first entered the market in the US in 2009 and has been marketed as a preconception tool, a prior to pregnancy screening tool. There are currently 4 products available on the market. One from 23andMe is available direct to consumer, so we can go and order it ourselves on the internet, spit into a tube, send off, get the results back over the internet. The other 3 products that are currently available, Ambry Screen, Pathway Genomics, and Counsel, have to be ordered by a physician. And as one of the previous speakers mentioned, the companies offering these tools are aggressively marketing these towards clinicians, and in particular to IVF practitioners, which I'll get into more shortly. 2 other products are scheduled to enter the market within, well, I think they should have been out last quarter, but they haven't quite made it yet, Good Start Genetics and GenPap. Including these 2 new to arrive to the scene technologies, these panels that are offered by these companies screen for anywhere from 22 to 160 recessively inherited diseases. And the disease severity within the product panels vary dramatically, from fatal diseases to childhood onset diseases to adult onset conditions. And in the area of direct-to-consumer genomic testing, which is where I've done some other work, by comparison to some other technologies, these are considered relatively inexpensive, ranging from $99 to over $450. However, depending on who this patient population is to be considered, this could be considered more expensive. So here I'm going to walk you through one of the company's websites to point out a little bit of the marketing that they do. So this is from Council. So the first piece is that they introduced this as a universal test, a non-invasive medical test meant to screen for dozens of serious diseases, including cystic fibrosis, spinal muscular atrophy, sickle cell anemia, and Tay-Sachs. They can't be cured, but they can be prevented. So what's key here, and this has actually been in the literature as far back as 2008, that this form of expanded carrier screening is being marketed as one of the only and first forms of actionable genetic testing available. So it's seen as preventive, and that this preventive testing is promoted through medical consensus. But if you actually click on the link for medical consensus, it takes you to the guidelines that I already described for cystic fibrosis carrier screening, for SMA screening, and for the Ashkenazi panel, rather than for everything that's on these panels. Further, as I mentioned earlier, this is marketed as a universal test. You don't have to be part of any particular ethnic group to benefit from it. However, there's not much time to talk about this today, but if you look at the populations that have been involved in the genetic research to compile information about risk factors, you can see that it's not population-wide, but rather population-specific. Further, here's some directions on how you can get your kit. There's a lot of spitting involved, and you can mail it in. Here you have to order it from a doctor, but it says you can get your results back online, and it's not entirely clear whether that has to be administered through a clinician or not. So here is my take on the potential user populations that might be affected by the availability of expanded carrier screening. One is individuals or couples who are prior to pregnancy, may not even be planning a pregnancy. Another are fertility patients, which have been the target of much of the marketing so far for these types of tools. This is a population that's intending and hoping for a pregnancy, but not yet pregnant. And finally, there's the potential for pregnant patients to be offered carrier screening, as is already the case in practice. However, what's interesting about this, despite the fact that it's being marketed as a preconception screening tool for women who may be planning a pregnancy either in the near or distant future, preconception visits to general practitioners and OBs are uncommon, and previous research conducted by Ellen Wright Clayton and colleagues has demonstrated that interest in preconception carrier screening has been shown to be quite low. So I'm conducting a study with my colleagues Rich Sharp and Deborah Cho and Jonathan Metcalf with focus groups of geneticists and genetic counselors regarding their attitudes towards expanded carrier screening. And in this data, which is not yet published but soon to be submitted, there is consensus among the population of genetics and genetic professionals that uptake may be highest for IVF patients and for women who are already pregnant, rather than this preconception population. So I'm going to focus the rest of my remarks here on the implications for women who may already be pregnant. So here are a few quotes from the focus groups that were conducted. And what I'd like to draw your attention to here is that there was some speculation within these focus groups that what's actually already being done is that these types of screening mechanisms for carrier screening are actually already done after women are pregnant rather than the preconception context. And it really is more of a marketing scheme, that the language around preconception is because that's what the companies want to sell rather than what's actually happening. And further, that it is the understanding among geneticists and genetic counselors that their understanding is that in actual practice, most women are getting this test when they're already pregnant. And further, the reason why a responsible approach to practice would emphasize pre-test counseling is because you want to make sure that an already pregnant woman understands what the limits of her options are before she gets the test. So what are these limits? So if you think about the box up at the top being a woman undergoing expanded carrier screening during pregnancy, if it turns out that she tests positive as a carrier for a rare Mendelian disease, it would require testing of her male partner. If both test positive for a recessive condition, then the question of prenatal diagnosis of the fetus will arise, along with the host of well-documented challenges of undergoing prenatal diagnosis during the course of pregnancy, which have been documented since even before the 1991 conference. If the prenatal diagnosis of the fetus yields positive mutation in the fetus, then the woman or couple may be faced with the classic challenge of deciding whether to terminate the pregnancy or continue the pregnancy and plan for a child with a genetic disease. So this leaves us with some questions. And just as Annie mentioned that she had 3 slides of challenges associated with expanding forms of prenatal testing, I think this is framed in more negative terms maybe than I would like, but I focused on more of the challenges here of prenatal applications of expanded carrier screening. There's potential for expanded carrier screening to contribute to the increased medicalization and tentativeness of pregnancy. This may expand choices for women to find out if they're carriers of a wider range of diseases, but as we've seen in the previous talks, that may raise a new set of obligations for women to take responsibility for that information. And I also think there's potential for increased surveillance of pregnant women and potentially of their male partners in the context of pregnancy if carrier screening is taken up in a widespread way. And the potential for prospective parents to feel increased responsibility for avoiding passing on genetic conditions that they have the knowledge and ability to prevent is exacerbated in this context with the added complexity of decision-making within an ongoing pregnancy. Expanded carrier screening may exacerbate an already complicated prenatal decision-making context by introducing more and rarer carrier traits to be evaluated, and with a higher volume and higher complexity of results. So in data that I'm not showing here, in the same focus groups, there was a concern amongst genetic professionals that the results would be complex not just for women and their partners receiving this information, but also for the clinicians who would be delivering the information. So the fact that there's a lack of medical professional consensus on carrier screening and the value of these new panels raises questions about the overall value of introducing complexities, these types of complexities into the prenatal context at all. So I'd like to thank my collaborators and our funder from the National Human Genome Research Institute, and I'll turn it over to Eric.
Okay. Do you have some slides?
I do, but they're on here.
Okay. Jim drives over here. Let me take this one out.
Okay. So while I'm getting my slides loaded up, I have a riddle for you. I was also at that 1991 workshop, but I wasn't the technology guy, and I'm not Neil Holtzman. So what am I? I'm also, the other possible explanation was that I've undergone a gender transformation since then. But that's, yeah.
You were staff. You were there.
I was staff. That's right. That is the answer. I was not at the table. I was staff, and that's by definition genderless. So I don't show up.
You were the male taking the notes.
I was. Okay, where did I go?
Try, maybe start, see if we can open it that way.
Yeah.
I'm going to open.
Yeah.
And it should give you yours from
From desktop?
it's not there. give us a hand? Thanks.
Computer.
Where's computer? Oh, there.
There's computer.
I guess I could have asked everyone else to give us a hand.
Right.
Is it in the folder?
Yeah. Here it is.
Oh, you
It's
already-
on a jump drive.
Yeah.
Oh.
Right. So I am going to pick right up from Michelle and the other speakers to give us more food for discussion. As one of, I think it was Elizabeth said, the third rail at that first workshop, which our bosses at NIH told us to go light on, was the A word, abortion. There are two other third rails, that is politically hot and often pejorative accusations in this realm that can derail the conversation pretty quickly. And that's accusations of eugenics or accusations of trying to design our offspring, of enhancement or intentional commodification and manipulation of our offspring. And that's where I want to go, since those are always in the background and can easily get submerged in the more proximal, practical issues of doing this kind of work. And the way I want to get to them is to think about the ways in which this concept of prevention drives us in both of those directions. Prevention is a perfectly laudable concept, and it's a concept that personalized medicine, personalized genomic medicine, is putting at the centerpiece of their new paradigm for healthcare. It's going to rededicate medicine to prevention rather than our current costly attention on the palliation of end-stage disease. You know, we're going to be able to get in earlier and preempt disease. That's what it's all about. But it's a concept that we get from public health, and it has a logic of its own. The President's Council of Bioethics noticed this in their report on newborn screening, which isn't our topic, but the logic is pointing in the same direction. They pointed out that once personalized genomic medicine becomes standard practice for adults, the logic of providing physicians with this powerful tool earlier and earlier in the patient's life may prove to be inescapable. Why not pack it all into our newborn screening panels, the full genome sequence? And sure enough, that was 2008. In 2012, there are discussions going on at NIH. Why not pack full exome sequencing into newborn screening and just have everybody's genomes done at birth? Well, that's not as far as that logic could go, right? It could go still further, because prevention is usually thought of in terms of these three distinctions in the world of preventive medicine, in the public health world: primary, secondary, and tertiary. Tertiary prevention blurs quickly with treatment. It's dealing with the end-stage symptoms of a health problem. Secondary prevention is trying to get at the health problem as quick as you can to prevent clinical manifestations. And for genetic services, at least in this report's definition, they say that's newborn screening. They already have the disease, but we're going to get in early enough to interrupt the clinical sequelae of having the disease. What's primary prevention in genetic services? Well, genetic counseling is a form of primary prevention because it provides couples with information about their pregnancy and reproductive risks and pregnancy options. Primary prevention would be about, well, not having those kids in the first place. And the logic of prevention is that primary prevention is always the ultimate goal for a preventive strategy. Much better to clean up the sewers and get the germs out of the water in the first place than to try to do something about infections further down the road. Sure enough, Council and the companies that Michelle is studying will promise to protect your child from 100+ genetic diseases. This may be an older web page than the ones you were showing, because maybe somebody's pointed out to them the interesting metaphysical problem with protecting your child through reproductive genetic testing. Still says that.
But it's like 3 times longer, the list goes down to 4.
Right. And as Michelle pointed out, they cast their business as about preventing genetic disease as a form of primary prevention. This has always caused a little bit of cognitive dissonance within the medical genetics community, particularly in the public health wing, where they want to talk about primary prevention and population level strategies, but they can't quite bring themselves to say that pregnancy termination is the goal. So you get quotes like this: primary prevention in medical genetics includes premarital counseling as well as prenatal diagnosis and pregnancy termination, but maybe this isn't primary prevention. Well, is it or isn't it, guys? What they're stumbling over, and this is my main first point, it's an old point for me and many in the room, is that there are 2 important different senses of prevention that are at play in these discussions. One is a very traditional form of prevention in medicine, and that is preventing the expression of a disease in an individual, like newborn screening. Let's call that phenotypic prevention, because in the genetic context, it's about preventing the disease phenotype from emerging, from being a carrier of the disease. It assumes the recipient of the intervention is going to survive the intervention to benefit from the prevention, among other things. And it contrasts with genotypic prevention, which is the prevention of the intergenerational transmission of the disease genes, which has a very different set of philosophical assumptions behind it, which I won't go into detail about. But it is that blurring, moving from let's go earlier and earlier into the life course to prevent diseases in patients, to let's go into the life course of families to prevent the birth of patients with particular diseases that is at issue here. So you do see public health department statements like this arguing that genetic information has a role in public health. It does have a role in preventing disease, disability, and death among people who inherit specific genotypes, but it concerns the use of medical, behavioral, environmental interventions to reduce the risk of disease among people susceptible because of their genetic makeup, does not include efforts to prevent the birth of infants with specific genotypes. Interestingly clear, for once, statement about where they're going to draw the line without a lot of argument about the public health rationale for why that line should be drawn there, except for the shadow of history, the shadow of the eugenics movement. And it does reflect, drawing that line there, saying we'll use genetics all we can to advance phenotypic prevention, but we won't take up genotypic prevention as a goal of prenatal testing, of reproductive genetic testing. It reflects the traditional stance in clinical genetics, in genetic counseling, that this is not about cleaning up the gene pool. This is not about the genetic welfare of the next generation. This is about giving couples, giving individuals opportunities to get information about the hard decisions they have to make in their reproductive lives and letting them make their own autonomous and non-coerced choices. Here's the President's Commission in a classic statement in the early 80s. Here's the statement from our predecessor workshop, a part of that manifesto at the end of the '93 workshop. Reproductive genetic services must ultimately serve personal, not public interests in improving the overall reproductive lives of women. Ideals of self-determination in family matters, respect for individual differences, ideals that lie behind the client-centered view of reproductive genetic services are jeopardized when these services, the goal of these services becomes prevention of the birth of individuals with a disorder or disability. And to the extent, of course, that services are evaluated in terms of numbers of babies born or not born, it jeopardizes that non-directive, client-centered, value-sensitive focus. Well, that shouldn't be news to anyone here, because I think that is the status quo of the official position, the field's position about how to draw the line between these two forms of prevention. Why we get nervous about companies like Counsel or others that seem to be doing more than saying, here's some information you might need to make your personal family decisions, and instead insinuating that the medical consensus is you ought to make decisions based on this information. So we reserve genotypic prevention. We still offer it to couples. We still defend it and defend couples' rights to make those sorts of choices, but we reserve it as a very much an elective and private affair, and publicly and professionally promote only the genetic interventions that affect phenotypic prevention. This is where, that's our bulwark against eugenics, right? But it also is where I think the flexibility of the concept of prevention is opening the door to the other side of the coin, the prospect of enhancement uses of these screening technologies. Because if in fact we take it seriously that these services are about letting women define their own reproductive health goals, we are opening the door to stretching the boundaries of what the tests can be testing for, as Annie suggested. At the first chapter of this discussion about gender selection in prenatal diagnosis, it seemed like there was a relatively quick answer that professionals could give when they were squeamish about acceding to parental requests for prenatal diagnosis for gender. They could argue, look, we're all about helping you make decisions that you have to make based on the health status of your fetus. As far as we know, gender is not pathological one way or the other. So that falls outside of our domain, and we don't have to give you that information until it's proven otherwise. That's, I think, where the boundary that we're going to have to test as a profession. This is not about state intervention, but about professional integrity and its boundaries. Where would clinicians draw the line? And whether we can use health and pathology as the boundaries we use to circumscribe our practices will get challenged as we're able to test for more and more things. What about women who say, but I am trying to prevent disease in my offspring. I'm trying to select for the least risky set of copy number variants amongst the embryos in front of me. I'm trying to select for the genetic variants that we now show provide protection, provide benefits, provide increased energy, provide better metabolism of drugs. It's all about my offspring's health, and so it should fall within that protected zone of decisions I'm allowed to make. One last point in that direction, why not the best in our children? That's a chapter heading not from old-style eugenicists, but from living bioethicists. There's a drumbeat in bioethics that says, yeah, right, why not the best? Take the lid off the choices people are able to make about their infants and let them go for it. So for those of us who worry about the effects of that on children, on parenting, etc., it's a question that pushes this issue of what the limits of reproductive testing should be. Thanks.
Thank you. I'd like to invite our panelists up here for discussion. We have just about 5 minutes for questions. So if anyone would like to ask a question, please come down to the microphones in the front.
it's now is it on? All right. This is specifically for Dr. Driscoll, but I'd be interested in all the other panelists' view on this. You had mentioned that with the advances of NI almost PD right now, that there's a need for guidelines to be developed for best practices. And you expressed regret about how those companies had not partnered with the professional organizations. And the other panelists and Dr. Lyerly had also acknowledged the benefits that patients receive from getting input from the Down syndrome community or from the disabled community that's being tested for. I wondered if the professional organization should also partner with the Down syndrome community in crafting those guidelines.
You know, several years ago, the professional organizations did partner with the National Down Syndrome Organization. And there has been a lot of information that's been developed to help counseling in these counseling situations. And I don't know if you have seen it, but there's a very beautiful booklet that was produced about Down syndrome. And there, I know personally I spoke with the head of the organization and arranged for members of ACOG, and I think there were probably members from the American College of Medical Genetics that were involved in that as well. So, you know, I think what we're trying to do is to educate providers about what it's like to raise a child with Down syndrome and to give them a very balanced view of that. And to make, I know there's also a move to have parents, families that have children with Down syndrome be available to counsel couples who receive this diagnosis during pregnancy. I don't, but maybe some of you have been involved in that. Anne, I don't know if you were involved in that.
The only thing that I would add to that is that if you're thinking about what the law requires with respect to informed consent and how you would make choices, you want people to have a full set of risks and benefits and alternatives to make decisions on. And if you don't incorporate the potential benefits of having a child and living with a child with Down syndrome into part of that mix, you're not ever going to really get a balanced approach. So I absolutely think you're going to have to include some of that as part of the information.
Thank you. And I think if the guidelines are going to be changed, it does provide the opportunity to write that in so that it becomes part of the practice, because it's not currently written in, except in the National Society of Genetic Counselors' most recent updates.
Yeah, I think, you know, I just wanted to comment about these, you know, companies are obviously out there marketing these products. And I think all of us who have practiced in genetics for a long time have been looking for the ideal non-invasive test, right? We know women who want the information. Many women want the information, but they don't want an invasive test. So I'm, you know, delighted to see that we finally have a test there. But, you know, I think that when we've rolled out other carrier screening tests, like with cystic fibrosis, a tremendous amount of thought went into how we were going to do that and to make sure we were prepared. And this just kind of hit everybody. And I think it does a disservice to our patients and to physicians who are grappling with how to best, you know, offer this to their patients.
Thank you.
Can I follow up the Down syndrome? I mean, it worries me a little bit. I've been approached certainly to see if a couple could meet another family with a child with Down syndrome, and generally you'll invite someone who's doing well, right? But it seems like a biased presentation that maybe you ought to invite someone to meet with that family who's doing well, someone who doesn't do so well, and someone who does well with abortion, and someone who doesn't do well with abortion. And that seems to be much more unbiased than just having to meet with a family who's doing well with their child with Down syndrome.
Mm-hmm. We really just have 1 minute left. I saw that you came down a little bit, but we'll have time at the break to talk. We have a break coming up. I'm going to try and keep us on time, but just if it's a brief comment, please.
It is. So as a pregnant OBGYN, my question is, you know, we've talked a lot about the first trimester screening and how much earlier we can get blood results, but nothing has been brought up about the idea of how much better our ultrasound technology is getting, and that a reassuring Maternity T21 Plus may provide someone with great information. They may not get a first trimester ultrasound because of good dates, and then they go on at 16, 18, 20 weeks and get their anatomy scan and are found to have a severe cardiac defect and encephaly or a host of other things that then become devastating and do not have genetic links necessarily. And how are we looking at, because a lot of my patients come in and are like, ooh, when am I getting my sex ultrasound? And they don't think about the congenital and genetic limitations of that. And I don't think as practitioners, we're all that good about discussing that.
Well, I can just tell you, we're debating this in our practice right now. Because some individuals feel there's a benefit to doing that first trimester ultrasound and looking to see if there is increased nuchal translucency or cystic hygroma, because that could potentially change what types of tests you might offer that patient. And I also know, and probably anybody who practices in OBGYN knows, that we can detect things like holoprosencephaly and anencephaly and omphalocele and things like that on a 12 to 14-week scan. So, there's no easy answer here, and we have to look at the big picture and come up with strategies that take all of that into account.
I'd like to close the session on that comment. Thank you so much. But it's not to stop the conversation. So we're going to take a break for about 15 minutes, and I'd ask that you be back at 2:45.
Yay.